Yes, good morning, everyone. This is the first panel of the workshop, and it's going to set the stage and describe the key aspects of the rather complex and unique problem and that outbreaks of infectious diseases pose to health, to public health, and to economies and to communities. And we are very happy that we have extremely knowledgeable people on the panel who can speak to these various dimensions. I'm going to ask 2 questions of each panelist, and they will answer the questions in turn. And at the end, we'll have an opportunity to take questions from the audience. Without further ado, I want to introduce the panel. We have Gordon Wu, who is a catastrophist with RMS, that's Risk Management Solutions, which is one of the main risk modeling firms. There are too few catastrophists in the world, and we are very happy that Gordon could come. We also have Captain Jordan Tappero from the Centers for Disease Control and Prevention in Atlanta. He is the Director of Global Health Protection and leading on the Global Health Security Initiative, or the American engagement in that. Global Health Security Agenda, I should say. We also have the Vice Minister of Integration and Development from the Ministry of Health in Mexico, Mr. Eduardo Gonzalez Pierre. And last but not least, we have Aaron Betru, who is the CEO of Financing for Development. So let me start with some questions for Captain Tappero. I will ask 1 question at a time, and then you have, as you heard, you have only 5 minutes to answer. But 5. Okay. Okay. All right. So up to 7 minutes. So it's a lot of subject and substance to cover in such a short period. But I mean, the disease control is a very discipline. So we'll be okay. Captain Tappero, the immediate impetus for this meeting and for the global health risk framework was the Ebola crisis. Could you describe the response to Ebola, the international aspects of it, and what was needed and maybe not delivered adequately to stop this outbreak from spreading and the crisis from emerging?
Well, thank you for the opportunity to talk and try and answer this question. We can look back at Ebola, where it was first discovered in 1976, and since that time there have been over 20 outbreaks in Central and East Africa, and they've all been stopped in a relatively timely manner. So what was different about the West African Ebola epidemic? To stop Ebola epidemics, you need several things. First, you need to have reliable surveillance that allows you to identify suspect cases and then follow their contacts and identify symptomatic contacts. For cases and symptomatic contacts, they need to be isolated. They need to be separated from their loved ones, and they need to be separated from their communities. Otherwise, there's ongoing chains of transmission. Where they're isolated, you need to have testing. You need to have testing so that those who test positive for Ebola stay and get the best of care possible, reducing their risk of death by about 50%. And for those who are not able and for those who are symptomatic contacts and test negative, they can be removed from the isolation, but they'll be followed for several weeks to make sure that they don't develop Ebola from their limited time in isolation. And then you need that care given by healthcare workers who have training in good personal protective equipment, the Tybexins that you've all seen. And then you also need community work for safe burials. So what happened in West Africa in December of 2013 was what we know of to be the first case. But disease was spreading in very remote areas and then cross borders with a highly mobile population from rural Guinea over into Sierra Leone and Liberia. And by the time it became announced to the world that there was a widespread Ebola epidemic in March, there were just too many chains of transmission. And so the failure was there was no surveillance. While disease was spreading, no one was aware, there wasn't contact tracing taking place. Then by July, we had disease for the first time reaching capitals with community-wide spread transmission by late July in Monrovia. In Monrovia, the story repeats itself later in Freetown, there was too few contact tracing teams to go out and identify the cases and the contacts to have them in isolation. Too few Ebola treatment unit beds to put people for testing and for isolation. There was only really by that time one medical NGO, Médecins Sans Frontières, that remained and engaged in the fight. And they were trying to scale up as rapidly as possible the number of ETU beds needed for the scale of the number of ill people, but they just couldn't scale up faster. They needed more partners. They needed more Ebola treatment unit beds, more contact tracing teams. And in addition, healthcare workers who had been interested were now no longer interested to come to West Africa to engage in the fight for several reasons. One, commercial airlines were closing down, so there was fear of being stranded. Two, the training that was needed couldn't be scaled up fast enough to ensure that you knew how to take care of Ebola patients in these special personal protective equipment. There was concern that you would be stranded, no way home even if you didn't get infected. And if you did get infected, there was concern about medical evacuation. And finally, there was no place for care locally at a high quality of care. So the expatriate community was really frightened and not willing to come and engage. And so we went through a process where communities had to learn how to do self-isolation while the world was asked to please respond. I think one of the things that helped in the response was when President Obama announced in mid-September that the Department of Defense would come. I think that was a real confidence booster because it brought forward that there would be logistical support, that there would be air transport support. And it also, they committed to building ETUs. However fast that pace was, it brought other international governments also forward, and it started the scale of the response that was able to finally begin catching up. Where are we now? We've come a long way in the response. In Liberia, we're almost at the end of 42 days after the last case was released from an Ebola treatment unit. And when that day comes, then Ebola will be said to be, Liberia will said to be Ebola-free of ongoing transmission. In Sierra Leone, I think it was just this last Monday, the last Ebola patient known Ebola case was released from the ETU, and that 42-day clock is starting. And in Guinea, we're down to about 10 cases in the last 3 weeks. So we hope to get that last patient out of the Ebola treatment unit and start that 42-day clock. So with any luck, we're getting close to that opportunity. I'll close by saying that what could have happened in Nigeria was abated because there were two elements that are critical to stopping Ebola. There was an incident management structure in place for stopping polio eradication, and that incident management structure was leveraged when the first introduction happened in Lagos. And there was also a trained workforce of over 50 field epidemiology trained field epidemiologists who knew the language and understood together how to work and do contact tracing teams and stand up an ETU within 2 weeks' time. So that when there was an introduction and ongoing chains of transmission, it was stopped within 3 generations of spread, and there were only, which is still too many, 19 cases. But can you imagine a population of 21 million people in Lagos, or The country of Nigeria, Africa's most populous nation of 180 million people, had Ebola gotten entrenched into those large urban areas, it would have put the whole continent at risk. And so we need to think about what was successful, for example, in Nigeria, and we need to make sure that we leave the rest of these at-risk countries with at least the minimum infrastructure to be able to respond should Ebola arise again, or should another event like Ebola happen in West Africa. We do need to be diligent in the days ahead. We know that sexual transmission is a real risk among survivors, and therefore these systems need to be put in place now. Thank you.
Wow, okay. You have two seconds to spare. Thank you very much. Now the next question is, now you touched upon the various parts of government that were involved, in the US, that it was not just CDC that was assisting, and also there were many partners. Now, were there any financial obstacles in doing the response efficiently and effectively and in a timely way, especially with respect to the involvement of the various sectors and multiple partners?
Thank you. I was fortunate to have the opportunity for CDC to be our first team lead when the public health emergency of international concern was declared, and leading our teams in Liberia, Guinea, and Sierra Leone in August and September. I would say that the biggest financial observation, concern that I observed was payment of a workforce. The true heroes of this response are the local populations. I talked about the NGOs, but I want to put that into perspective. The medical NGOs, we need their expertise for sure to run Ebola treatment units and contact tracing teams, but actually the day-to-day work is about 90% done by a local workforce. If you look in Liberia alone, most of the workforce had not been paid reliably before Ebola struck, and after Ebola struck, then people simply weren't getting paid. Those are the true heroes that continued to come to work, to continue to address the health risks of those who were ill, knowing that they could be putting themselves at risk. Because one thing that always happens with these viral hemorrhagic fever outbreaks, especially Ebola and Marburg, is that the hairbringer of these events is death among healthcare workers. So these workers knew that they were taking a big risk, and they weren't even getting paid. And so some of the early requests for financial support were to make sure that there were financial systems in place to ensure that the workers would get paid. And one of the things that happened early on was to, as an incentive to get the workers to continue to come to the clinics and the Ebola treatment unit facilities, there was an enhancement of the government pay scale for these workers. And that pay scale became one where it was out of range for what the medical NGO community could sustain. And so I would say this is one of the financial lessons learned of one of these big events. We need to ensure that there is a financial system that ensures payment of the workers, and that there is an equitable scale from the very beginning so that it doesn't lead to chaos and people not wanting to come to work or wanting to jump from one organization to another, and then everyone's competing with themselves with such an important asset that is too few in number at the get-go. I think there are a couple other issues that are solved by money and not. As I mentioned, for the healthcare worker systems, it's money and systems to ensure payment. But money, early on, I think there was a lot of concerns about who would pay for medical evacuation of any kind of either medical direct care worker or someone involved in contact tracing and response or laboratory testing or on down the line of the cascade of what's needed in these events. And so medical evacuation, I think countries struggled with early on. So we need, as a global community, to get ready for a next event of this scale and make sure that we have systems in place for medical evacuation so that those medical NGOs that are willing to respond and those governments that are willing to respond, their healthcare workers are not starting off by asking the question, if I go, can I get home? If I go and get sick, can I get home? And we need to work on that. The other thing is, infection control is real critical. And if we really want to think about long-term financial problems, in most primary healthcare centers, if not even middle or higher healthcare centers in West Africa, there is no soap and there is no running water. I think that basic infection prevention control practices require soap and running water, let alone some basic latex gloves and even modest personal protective equipment. And those commodities are essentially absent. Getting to the scale of personal protective equipment with Tyvek suits and all of the hoods, covers, and boots, and that's on another scale. But the basic for countries around the world of water and sanitation, soap, water in healthcare facilities is critical. And the last big thing I would say is, if we look at some of the promising outcomes of this unfortunate epidemic, are that we now have Ebola vaccines that have been brought forward, and we know they're safe, and we know that there's at least efficacy with one of the products, and perhaps even more. And I think early on, if we look at development of vaccines for viral hemorrhagic fevers or the next SARS-like illness, there needs to be financial support systems for these medical products. I know from Dr. Zhao's presentation that was addressed in Hong Kong last week, but we do now have product of a vaccine, and I think there's a lot of discussion going on in the international community about purchase of vaccine, how it should be utilized, et cetera. And it really be very important, I think, for us to get a vaccine development fund or something of that nature to be addressed, not only for Ebola, but for future pandemics or epidemics that can be controlled with new vaccine tools or other medical products that either can be brought to scale quickly or that need to be evaluated quickly should these events be sustained for longer than a year or more. Thank you.